Welcome all to the education Ampok session 28. This session, we have the two eminent examiners on board, Dr. Akhil Kapoor from, he's an associate professor, TMH Varanasi, and Dr. Manu Prasad, senior consultant, medical oncologist at Aster MIMS, Kannur. The candidate for today's presentation is Dr. Kalai Bharati. He's DM trainee at RCC Trivandrum. Doctor, we can start. Man Prasad sir, can we start?
Yes, we can start.
Good morning, sir. Good evening, sir. One second.
Good evening. Please start.
Yes, sir. I'm sharing the screen. 1 second, sir. Are you able to see my screen, sir?
Yes.
Good afternoon, everybody. I'm going my presentation. I'm Kalai Bharati from RCC Trivandrum. Going to the case. This patient is a 64 years old male hailing from Trivandrum, who is a businessman by occupation, who owns a grocery shop. Came with chief complaints of cough with dyspnea for 1.5 months and hemoptysis 2 weeks back. History of presenting illness. History of cough, insidious onset and progressive in nature over past 1.5 months, associated with productive sputum recently. No specific aggravating or relieving factors. History of dyspnea, grade 2 MMRC, insidious onset and progressive over past 1 month. History of hemoptysis, 2 episodes, mild in amount over past 2 weeks. History of fatigue present for the past 2 weeks. No history of fever, loss of appetite or loss of weight. No history of hoarseness of voice, dysphagia, puffiness of face, edema of upper or lower limbs. No history of chest pain or palpitations. No history of abdominal pain, distension or jaundice. No history of bone pain. No history of headache, vomiting, blurring of vision or weakness of limbs or seizure. No history of bowel or bladder disturbances. No history of melena or hematochezia. Patient underwent some supportive treatment for the above complaints and evaluated at nearby hospital with imaging and then referred to our center. Past and medical history. Patient has a known case of type 2 diabetes mellitus, systemic hypertension, dyslipidemia, and atrial fibrillation on cardiac drugs and other supportive medications. No history of pulmonary tuberculosis or COPD history prior. No history of previous form of any cancer, or no history of previous surgery, or no history of any radiation exposure. Personal history: former smoker with 6-pack years, stopped 10 years back. Occasional alcoholic. Family history: no family history of any cancer. Summary: 64 years old male businessman with type 2 diabetes, mellitus, systemic hypertension, atrial fibrillation, and supporting medication, who is a former smoker with 6-pack years, with no prior personal or family history of cancer, now presented with complaints of progressive cough with dyspnea for 1.5 months, and 2 episodes of hemoptysis over past 2 weeks associated with fatigue.
Okay, so yeah, okay. So what is your impression from the history?
Sir, from the impression from the history, a patient has is a smoker, a former smoker with 6-pack years, and with the respiratory complaints of cough with dyspnea, which is progressive over the past 1.5 months, and with hemoptysis episode. With this age group, 64 years male, with all this comorbid, with this smoking history, and pertaining to this respiratory complaint, my close differential diagnosis would be primary malignancy lung or metastatic lung disease. Obviously, infective etiology has to be ruled out, but this history, no history of any fever or acute any history of fever or any other treatment of prior history of PTB has been there. So my preferential differential diagnosis would be primary lung malignancy or metastatic lung disease.
Okay, you've given a detailed negative history. Did you mention about anything related to cardiac issue, like whether orthopnea, PND, or palpitations?
No, sir. History of only dyspnea of grade 2 was there, but otherwise,
yeah, so that should be mentioned here because
edema. Okay, sir.
Yes, he's having AF already. There's a cardiac history,
yes, sir.
And hemoptysis dyspnea all can be part of a cardiac disorder also. So that should be mentioned. All the other things you mentioned in detail. And
Yes, sir.
regarding AF and medications, do you get any idea about what all medications he's taking?
Patient had a history for paroxysmal AF, sir. So patient was on a warfarin previously, but the patient was withheld on warfarin because of the hemoptysis episode when he presented to the nearby hospital, and then he underwent evaluation. And when he presented to us, he was almost off treatment for almost
Okay,
1.5
so
weeks.
he was already on anticoagulants. I think that also
Yes,
can
sir.
be mentioned because the symptom is hemoptysis.
Yes. Okay, sir. Okay, sir.
Okay. So your first diagnosis, primary lung cancer. And why did you mention
Yes.
about the metastatic lung disease as one of the differentials?
Because
there are no systemic symptoms, and it is not very common to have hemoptysis with metastatic lung disease compared to
yes, sir.
primary
It's
lung.
very rare, but primary lung would be my first, but second
Yeah,
possibility.
first should be
Still,
primary lung
yes, sir.
and
Yes,
other
sir.
disorders like tuberculosis.
Yes,
So
yes, sir.
you mentioned
Yes.
you was a former smoker. So can you
Yes,
mention
sir.
about the different type of smokers?
Yes, sir. Former never smoker are those persons who has never smoked or those who have smoked only less than 100 cigarettes in their lifetime. And former smokers are those who have smoked at least 100 cigarettes in their lifetime and who have quit smoking more than 1 year. Recent smokers are those smokers who have smoked cigarettes from but they have quit like 1 week to 1 year, sir. And the current smoker are those persons who smokes cigarettes daily or in some days in the week, sir.
Okay. So
And then
you said your patient stopped smoking 10 years back. So what are the implications on his risk for lung cancer?
Sir, risk for lung cancer, there is almost in if we quit smoking, almost in next 5 years of absence of smoking itself, patients' risk of reduction, risk for lung cancer decreases by 50%. And if it goes beyond 15 years, almost 80 to 90% risk reduction can be there. And also all cause mortality also patient gets all cause benefit of mortality about 6 to 7 years of life expectancy can be patient can get if patient is absent for 15 years of smoking.
Yes, right. After 10 to 15 years, the risk will
Yes,
come
sir.
down by 80 to 90%.
Yes,
So,
yes,
but it will never be as same as a non-smoker.
non-smoker is.
Okay. So you mentioned one of your strong points for considering the carcinoma lung is smoking status.
Yes, sir.
So what is the current situation of smoking related lung cancer? What is the status of lung cancer in smokers at present? What percentage is contributed by the non-smoker?
I mean,
Especially
smoker
in our part of the world.
Non-smokers exact percentage of lung cancer statistics in non-smoker I don't know for sure, sir.
So in our part of the world, that is Southeast Asia, the incidence of non-smoking associated lung cancer is very high. Around 40 to 50% is not related to smoking.
Okay, sir.
So recently there was a
Okay, sir.
publication from multiple centers led by TMH in this Lancet, which has mentioned about the epidemiological pattern of lung cancer in Southeast Asia. That is clearly shown that other than smoking is much higher in this part of the world. So what are the other causes of lung cancer?
Apart from the smoking, per se, if patient has any exposure to combustion fuels, or patient has exposure to prior history of any radiation history, or history of any radon exposure or terrestrial radiations also, or any uranium exposures, or any passive smoking also, and then also third-hand smoking due to terrestrial tobacco.
The most important is air pollution. So
Air pollution.
even study attributed the increase in incidence in non-smokers to air pollution, especially the particulate matter-related pollution. Okay, so please go through that article that gives a clear picture of the epidemiological pattern in our part of the world. Okay. So your first diagnosis is carcinoma lung. Okay.
Yes.
Yes, proceed.
Yes, sir. Yes.
Apart from smoking, I would also like to.
Okay. Yeah, please.
Yes. Hi. Good evening.
Good evening,
just
sir.
I wanted to make a point related to the smoke related to cooking of the food as well. So in the Taiwan
Okay, sir.
study, they had mentioned about that as well. So I think it is important to
Okay,
know about that as well, because not
okay,
only for
sir.
lung cancer, for both other cancers, it is very, very important. So it would
Okay,
be
sir.
apt if you know about those indices as well.
Okay,
Yes.
sir.
Okay. Okay.
Okay,
And
sir.
then if the examiner is willing, the VIVA can go towards the various carcinogens present in smoke, at least name
Okay.
4 to 5 of them, which are the
Thank you,
most
sir.
common ones and most important ones, carcinogens. So that will be
Okay, sir.
useful.
Okay, sir.
Yes, Dr. Mani, you can
Okay.
direct the discussion further,
Yes, sir.
please.
Okay, sir. Coming to the general examination, person is Eastern Cooperative Oncology Group performance status of 1, conscious oriented, no pallor or icterus or clubbing or pedal edema, no peripheral lymphadenopathy. His vitals are normal, no JVP elevation. Height is 170 centimeter, weight 65 kg. BSA is about 1.74 meters square. BMI of 22.5 kg per meter square. There were other general examination, but no facial edema, no conjunctival congestion, engorged neck or chest veins, or upper limb edema or hoarseness of voice, fundus no papilledema, no ptosis, meiosis, or enophthalmos. Coming to systemic examination, respiratory system inspection, chest wall is bilaterally symmetrical, moves equally with respiration, no scars or sinuses. Coming to palpation, trachea is in midline, chest wall measurements and palpatory findings showed bilateral symmetrical moves equally with the respiration. Percussion, all areas are normal resonant note. Auscultation, normal vesicular breath sounds were heard in all areas. Ronchi was heard in right infraclavicular and suprascapular areas. Vocal resonance was normal in all other areas. CVS S1 S2 heard, no murmur, perabdomen, no organomegaly, or no moss felt. Rectal and genital examination was normal. CNS, no focal neurological deficit, no papilledema. Summary, 64 years old male with comorbidities of diabetes mellitus, hypertension, and atrial fibrillation on supportive medications, and who was a former smoker with 6 pack years. Presented with complaints of progressive cough with dyspnea for 1.5 months and 2 episodes of hemoptysis over past 2 weeks associated with fatigue, and on examination found to have V's over the right infraclavicular and suprascapular areas. Otherwise, no other findings. My differential diagnosis would be still considering the age with smoking risk factor, and then symptoms of cough, dyspnea, and hemoptysis. My differential diagnosis would be right primary lung malignancy or metastatic lung disease, or any infective etiology still have to be ruled out, other benign causes.
Okay. So in the examination, is there any features of atrial fibrillation? You didn't mention about that.
No, sir. At that time, the time of actually, patient is known as a paroxysmal AF, sir. Patient's already on regular medications. At the time of presenting, a patient did not pulse rate were regular, sir.
Okay. Please don't miss out on such things
sir.
that may not be important, but I mean, it is important not the significant findings. Okay.
Yes, sir. Yes, sir.
And
yes, sir.
In the examination, what is the importance of neurological examination here?
So neurological examination, first, whether there is any neurological deficit to rule out any metastatic, if patient has metastatic lung disease to brain, patient can have neurological deficits due to cerebral edema. Patient can have papilledema, or a patient can have paraneoplastic syndromes like myasthenia syndrome, or any sensory disturbances like axonal neuropathy can cause, and then cerebral ataxia can happen.
Yes, right. So because you mentioned about fatigue, so that can be due to disease, but sometimes that may be a manifestation of a neurological, paraneoplastic neurological syndrome. And Horner's as someone has already mentioned in the chat. So that's it. Dr. Akli, you have anything to add?
Yeah. So I think that was important. Most common symptoms for CNS will be due to the disease per se, due to metastatic disease, and sometimes rarely due to paraneoplastic. But definitely you should be aware of all the common paraneoplastic syndromes associated with the cancers, especially small cell cancers. And
Okay, sir.
if the examiner will definitely in small cell, the viva will go towards paraneoplastic, that is for sure. So
Okay,
you
sir.
should be
Yes, sir.
aware of in detail. We'll come to that as well. So which antibodies are
Okay, sir.
responsible, what paraneoplastic syndrome
Okay,
is
sir.
with which antibody. I think
Okay,
all
sir.
these factors will be important. Should we ask
Okay,
it
sir.
now or later, Dr. Manu?
Yeah, we can discuss it now itself. No
Yes,
problem.
yes, yes, yes.
Cover it today.
Yes,
So,
sir.
which is the most common paraneoplastic syndrome in small cell cancer?
SIADH, sir.
SID, very good. SID. So,
Yes,
how
sir.
is it caused, why it is caused, and how will you diagnose it?
Because of the ectopic ACTH secretion, it can be diagnosed with patient can have euvolemic hyponatremia with urine sodium will be increased more than 40 millimoles, and then urine osmolarity will be increased. Serum osmolarity will be decreased, and decreased serum uric acid can also be there.
Okay. So,
And
what is
patient
the
can have
hyponet?
clinical manifestations of yes, clinical
Yes.
manifestations of hyponatremia can be there if like disorientation or augmentation or confusion or fatigue
Mm,
can be there.
okay. Was there any some symptoms in this patient
No, sir, except fatigue, no other symptoms were there, sir.
except fatigue? Others responded. Okay.
Yes, sir.
Okay. So, so if there are any suggestions of hyponatremia in the labs, for example, sodium is around 120,
No, sir.
but the patient
No,
doesn't
sir.
have any symptom, what will you do? How will you manage it?
Treat the disease, sir. I will
Treat the disease.
like, treat the disease and then I can give supportive IV fluids if there is no contraindications or under salt-rich diet. I will advise.
Okay. So, but if there is SIADH and you are giving
Uh,
IV fluids, will
uh,
it improve or
I will in this
complicate this?
actually
Complicate.
sorry, sir. I have to restrict the free fluid intake.
Mhm.
Salt-rich diet we have to give, and then
So,
I will treat the
so it
disease, sir.
So actually, here you would the point is correct, but there needs to be a balance because you are going to
Yes,
start
sir.
chemotherapy as well, and there is
Yes, sir.
expectation of some amount of tumor lysis as well. So you cannot
Okay, sir.
completely restrict the fluid as well, and you cannot
Yes, sir. Yes, sir.
completely give
Okay.
so much of fluid as well.
Okay.
So you will say
Okay, sir.
that I will monitor intake output very closely, and
Okay.
will
Okay,
try
sir.
to have 500 ml of negative balance. Dr. Manu,
Okay.
is
Okay,
it
sir.
correct?
Yes, Dr. Yes, I agree.
Yes, yes,
And
yes.
just one question
Okay,
on
sir.
that. What is the essential difference in the management of endocrine versus neurological symptoms, syndromes in lung cancer? I mean, paraneoplastic.
Sir, I don't get you, sir.
No, treatment part, endocrine paraneoplastic manifestations and neurological paraneoplastic manifestations. What is the essential difference?
Actually,
Treatment of this.
it can be actually it can be reversible in we have to both the cases we should treat the disease, sir. Here in neurological and mostly reversible, sir. We should we may need to consider for other drugs like
Yes,
steroids or Plex or tacrolimus or
correct.
something
So
like that to be
endocrine, the
needed, sir.
treatment is treatment of the disease, whereas in
Disease, yes, sir.
neurological, it is not just the disease alone. You have
Yes,
to
yes, yes, sir.
use other modalities. Okay,
Yes, sir. Yes,
you can proceed.
yes.
So how will you work up this patient?
Sir, workup initially, since my differential diagnosis, close differential diagnosis is primary lung malignancy or metastatic lung disease, I'll first initially go for basic investigation of chest X-ray to look at any anatomical anatomical lesion is there or not, or since patient is having dyspnea also with throughout any, but clinically no evidence of effusion, but still I do chest X-ray initially, sir.
Okay.
And then followed by that, if I don't get anything or if at all,
Hello.
I think we lost his connection.
Suddenly lost the connection. Okay.
Yeah, yeah. Hosting
Murli, can
can
you check with him?
Hmm.
He will join
Yes,
soon.
it's back. Okay.
So most of the time when the patient is arriving to you, the patient will have some of the investigations with him or her. So most of the time X-ray or sometimes a CT is already there. So in that case, do you want a repeat CT chest or you want a complete CT thorax abdo-pelvis versus FDG PET? Are you able to hear?
Abdominal pelvis or PET-CT, sir.
Okay.
And then after
Apart from that,
for confirmation of the leaf, if at all I found any lesion in the lung, I'll go for as I had my differential diagnosis. I'll go for confirmation with biopsy, sir. Which may be image guided or bronchoscopy guided. But before that, I will do basic investigations like CBC, coagulation profile, and other biochemical parameters, and serology also.
So what do you expect? What derangements are expected in the routine profile which you are doing?
In CBC, if patient maybe since patient is having hemoptysis, as per the history it's mild, but if it has been massive, I can expect anemia, or also as due to the course of paraneoplastic, also patient can have anemia or thrombocytosis or leukocytosis in CBC picture. And if there is any coagulant infection, consolidation is that patient can have increased total counts. And in coagulation properties, already patient is a known case of atrial fibrillation. Patient was on warfarin before, but he has stopped 1.5 weeks back. So I will look for the coagulation profile to be normal so that I can proceed for biopsy. And other RFT and LFT parameters. To do a CT thorax abdominal pelvis with contrast, I should ensure whether creatinine is normal. And then the LFT parameters, if at all any metastasis has been there, I can look for any derangement in the LFT parameters. Apart from that, for planning of chemotherapy in later time, I will need to ensure the adequacy of liver and kidney functions. And serology, of course, for universal precautions.
You should mention specifically about the tumor lysis, especially as we are suspecting, discussing small cell and also calcium electrolytes, including calcium levels.
Yes. Electrolytes, I will look for any hyponatremia or hyperkalemia there, or patient has any hypercalcemia of malignancy because of, but it's not common in the small cell, but can be in squamous cell carcinoma. These are all the things which I will look for.
So, okay. So, do we have the investigations here?
Actually, it was all normal, sir. Or LFT alone was deranged, sir. 0.8, 105, 51, and 85. SGOT alone was 105, sir.
Okay. What did the X-ray show?
Chest X-ray. This is the plain chest X-ray PA view of the patient. Properly positioned and adequate exposure. In this X-ray, trachea appears to be slightly deviated to the right, sir. And then there is cardiomegaly is present. And then coming to the lung fields, there is increased bilateral bronchovascular markings. But other than that, a doubtful patchy opacity present below the right middle head of the clavicle. Otherwise, bone, rib cage, and then other soft tissue or normal.
So there is striking cardiomegaly, right?
Yes, sir. Striking cardiomegaly.
Okay. What about the other reports?
Yep. This is the CT report, sir. My impression, there was a soft tissue attenuation nodule with spiculated margin seen in the right lung upper lobe with significant mediastinal and intra-abdominal nodes. The size of the lesion was 1.9 into 1.6 centimeter. There was moderate to massive pericardial effusion, few hypoattenuation lesion in liver, largest measuring 1.2 centimeters in the segment for possible metastasis, and prominent bilateral level 2 cervical nodes of approximate size of 1.1 centimeter on the right side, largest.
So if the patient has come with a CT scan already done, will you ask for a PET?
Since in this patient, since already looks like a stage 4 disease, I won't go for PET CT. Otherwise, if I'm going for a radical internet patient is not having any significant mediastinal nodes or any other nodes, I would ask for PET CT for staging purpose, proper staging evaluation.
If PET CT is not available, what else? What all investigation will do if you're suspecting small cell lung cancer?
I can go for with CT neck thorax rhabdominal. Apart from that, I can go for bone scan, and then for bony metastasis, and for the MRI brain for brain metastasis.
Yeah, so you need to do a bone scan and bone marrow examination. So does the PET scan really upstage the disease compared to the other investigations? What percentage of patients?
Around 10 to 15%. I'm not sure the exact numbers.
Sorry, how much?
10 to 15%.
Yeah, that is generally PET scan upstates in all the cancers. We say this figure 10 to 15. I think in small cell it's even lesser, like it's between 5 to 10%. But definitely with availability and convenience, it is always better to go for PET CT. But the number of patients who may be upstaged are much lesser compared to other malignancies.
Okay.
Yes, yes, Dr. Agil has put out some points.
Yeah, that is related to high-risk features of cancer. For example, if a patient has a family history of cancer within first to third degree, there's a passive smoking exposure, history of TB, COPD, cooking index. That is what I was trying to highlight in the Taiwan study, talent study, which was there, and not using ventilator during cooking. These are related to the smoking and other related points. These are useful. Sometimes examiners, when asking specific points, they can ask these points. These are useful.
Because you mentioned this, what is the relevance of tuberculosis in lung cancer?
It can be a patient had the previous history of tuberculosis and the patient developed, or hello, if patient had developed fibrosis, patient can develop scabrous carcinoma on the later times.
Yes, yes. I mean, this association was seen around 1% of the patients in one of the Indian studies. And also, most importantly, around in India, lung cancer patients around more than 20 to 25% might have already received ATT before we start treatment for
correct.
lung cancer.
Completely
and also, there are a
agree.
lot of implications during treatment, including interactions with ATT. So TB is very important here also. Okay, so the question in the chat box is whether bone marrow is mandatory. I mean, if we are doing PET, there is no need to do bone marrow. But otherwise, if you're not doing PET, it is preferable to do bone marrow, especially if there are some abnormalities in the blood counts. Even otherwise, generally bone marrow is recommended in the pre-PET era.
Yeah. Presently, I think nobody uses bone marrow biopsy. But yes, thus one should be known that if it is not feasible to do PET and a patient is having some changes in the counts, that means 2 cells are at least affected out of hemoglobin, platelet, WC, bone marrow will be recommended.
Yes. So Dr. Kale, you can, so CT scan is shown metastatic disease with the pericardial effusion. There was no features of tamponade, no?
No, sir. No tamponade. The patient vitals, they're all stable. Even JVP was not elevated.
Okay. You mentioned that.
No elevations.
Okay. Then what will you do?
Then for the confirmation, then biopsies.
You must do an urgent echo also. So there may be pending tamponade before you're planning for a bronchoscopic or guided biopsy. first do an echo and assess the effusion status.
Yeah. So assessing the effusion, pericardial effusion in this patient becomes really important because the patient has history of AF, the patient has significant pericardial effusion visible in the X-ray. So you should assess it. Either preferable is by 2D echo, or else you can do a just simple ultrasound and see the thickness of the left ventricular apex to the tip of the pericardium. If that is more than 10 mm, that is required to be tapped at least.
Then we initially aspiration, but it was inconclusive. So
But the CT scan was is it likely to be accessible in bronchoscopy?
No, sir. No, sir. It's not nearby any large airways or bronchus. So I think it will not be feasible. But
Yeah. I think
initially, but it was
yes, in such cases, we can directly go for a CT guided biopsy. And after, if you have some anticoagulation, after stopping that should not be forgotten. Okay.
But we went for biopsy from the metastatic lesion in the liver, sir, actually.
Okay.
Investigated. It came out to be metastatic neuroendocrine carcinoma correlating with history and imaging findings. It was small cell carcinoma lung, and IHC were CK diffuse positive, synaptophysin diffuse positive, chromogranin negative, and CD56 was also diffuse positive.
Okay. So CK synaptophysin and CD56 positive.
Positive, yes. Chromogranin alone was negative.
Okay. Generally, what happens to TTF1 in small cell lung cancer?
It can be positive up to 80 to 85%. It can be positive, sir.
Yes. Okay. All right. So this is biopsy from a lesion other than lung. So is there any difference between the small cell lung cancer and extrapulmonary small cell cancers? Are they same or different?
I think 95% of them will occur in the lung only. Only 5% will occur in the extra, but management wise it is not different, sir. It is of same.
Yeah. Management is somewhat same, but biologically these are different entities because the association with smoking is much lesser in extrapulmonary small cell cancers, and the propensity for brain metastasis is much lesser compared to the pulmonary small cell cancers. Okay. Anyway, so biopsy suggests your small cell lung cancer. So what is the final diagnosis?
Final diagnosis is stage 4 small cell lung cancer, extensive stage.
Okay. So what do you mean by limited?
Limited is stage 1, 2, 3 small cell lung cancer groups with lesion confined to one hemithorax, and all of the lesion can be encompassed within a tolerable radiation limits.
Okay. All right.
Okay. So I think you should avoid the term stage 1, 2, 3 and stage 4 because that is not a standard nomenclature when you are discussing small cell. But yes, ED extensive and small limited, you gave the correct definition. So it is basically based on the radiation portals as you highlighted. And also when you're seeing the pathology report, here we can't see the details of the pathologic assessment on the, it is mainly telling directly metastatic NEC and then IHC is there. So I think most of the time our pathologists report it in detail that sheets of cells are arranged and all have small cells, large nucleus. So all these details are also become important sometimes. And when it is so obvious that most of the time, even it doesn't require 3 or 4 IHCs also, single IHC might be enough when you want to save the IHCs. So pathological description is also important, though it is not mentioned here, but in other cases, most of the time it is mentioned. And that is very pathognomic of a small cell.
So how will you manage this patient?
This patient is extensive stage small cell lung cancer. I will counsel patient for I will first do basic blood investigation workups to see whether patient is fit enough. like CBC and biochemical parameters.
That we've already done, no? That's all normal.
That's all normal. So I'll plan for my first line of management would be chemoimmunotherapy with atezolizumab 1200 milligram a day one plus etoposide of 100 mg per meter square day 1 to 3 plus carboplatin which is called in our setting carboplatin of AUC 5 day 1 every 3 weeks for 4 cycles followed by reassessment. The reassessment we will do, look for since patient initially underwent CT thorax abdomen pelvis and since it's extensive phase we will do CT thorax abdomen pelvis and MRI brain also because earlier patient was not symptomatic for any brain met. So by reassessment time we will do along with the CT thorax abdomen pelvis we will do MRI brain
so just one question. So you will do an MRI brain for this patient even if he's asymptomatic?
No, sir. In our institute, we don't do routinely, sir, unless otherwise patient is symptomatic. Sir.
Okay. Okay. So your plan is etoposide, carboplatin, and atezolizumab.
Atezolizumab for 4 cycles every 3 weeks, followed by reassessment. If patient has adequate response, we'll go for atezolizumab maintenance, and then follow up MRI or I will consider for PCA, sir.
Okay. So you think immunotherapy will be beneficial? So why are you choosing atezolizumab? What is the other option?
Other option is durvalumab, sir, Caspian study. Yeah.
Okay. Why do you prefer atezolizumab?
Yeah, I think in exams it will be better to mention both the options directly without giving preference to one specific drug. We can use either of the two. Both have not been directly compared, and both have shown survival benefits. So in the exams you can give both the options, and if the examiner asks in the next step, you have to mention the differences in the trials, and you can mention about the cost aspect as well, why you are preferring one of the over the other. So you can mention that. And also, since you mentioned that MRI brain is not done as per the institutional protocol, this is fine. But in the ideal scenario, going by the books and going by the standard teaching, MRI brain should be recommended. But yes, I agree. Some institutes, including ours, in extensive stage, do not perform it routinely. So that is fine. But you should be aware that MRI brain is ideally indicated. But if resources are constrained, it can be avoided if the patient doesn't have symptoms. Dr. Manu, I think I made the correct point.
Yes, yes. I mean, if you're using immunotherapy, I think it is less important, especially when you use atezolizumab. There's no difference. But if you're not using immunotherapy, I think you should mention that ideally it should be done. But I mean, practice, I mean, most of us are not doing. So as Dr. Akhil mentioned, you just say chemoimmunotherapy as the next step. If the examiner asks, you need to discuss the differences between the trials. I mean, not in detail, but the basic principle. So what are the difference between these two trials? And if you prefer one molecule, what is the reason?
I'll go for atezolizumab because it's only like 4 cycles followed by atezolizumab maintenance only. Durvalumab, PCA is not recommended in durvalumab trials.
Sorry, Dr. Kale, I think your voice is not very clear.
Hello, sir. Can you hear me now, sir?
Yes. Now it's better.
Differences is like in atezolizumab we use only etoposide and carboplatin.
Yes.
Here either carboplatin or cisplatin is used in Caspian in durvalumab. And then it's only 4 cycles are allowed in atezolizumab. Here either 4 or 6 cycles, up to 6 cycles are allowed. And then prophylactic radiation is allowed in atezolizumab group, but in durvalumab it's not given as per trial. And then overall survival wise, it's almost 12 months versus 10 months. Here it's almost 13 months versus 10 months. Both are equal.
Okay. So generally, you are more comfortable in using carboplatin along with the immunotherapy, so you prefer atezolizumab. Okay. In practice, what is the main obstacle in using immunotherapy in small cell lung cancer patients? I mean, leave apart the cost. Otherwise, what is your concern in real world setting?
Going for consolidation RT, or if patient has very good response post 4 cycles initial chemoimmunotherapy, and then patient is fit enough for consolidation thoracic RT, there may be chance for radiation.
Okay, that is one point I agree. So you mean there is a role for consolidation RT in extensive small cell lung cancer. If there is good response, we can irradiate the residue, and that is shown to have a survival benefit, right? So that is not, I mean, that is not included for the atezolizumab trial. I think for the other trial that is permitted. In the IM Passion trial, the thoracic RT is not permitted. Okay, that is one point. Then otherwise,
patient had extensive lung disease, giving atezolizumab, if patient develops the radiation immunity, still it could hamper the lung functions.
okay. Yeah, and the problems in practice, most of our patients' performance status is not very good. So all these trials clearly say it should be in good performance status patients. But small cell lung cancer most of the time presents with poor performance status, and we need to give some tailored therapy. And many a time it may not be practical to use immunotherapy also. Okay. Okay. So if you're using immunotherapy, what all investigations extra will you do? What all things will you look for?
Look for in our we usually do a thyroid function test and the cortisol level.
Okay. Okay.
That is what we do in our percentage. And we will monitor for every 3 months the TFT and the cortisol levels. We will monitor.
So what is the response rate you are expecting with these drugs, with chemotherapy or even immunotherapy?
Response of survival benefit of as per the above most of
no. First give response rate. First give a response rate. So the question is, so the question is, with platinum agents, what is the percentage of patients who are expected to show a response in small cell lung cancer? Do you expect it to be low, medium, high? If either of these three, what other of percentage?
Very chemosensitive disease, so medium.
Yeah.
Medium to high, medium benefit will be expected, so close to 50%.
So response rate is expected to be high, correct? 70 to 80% patient should show some improvement, correct? In the chat box, somebody mentioned 30%. That's quite low. That is 30 to 35% is expected even in adenocarcinoma lung with pemetrexed carbo alone. And when you are adding treatments like bevacizumab in adenocarcinoma, you will add 5% to 10%. If you are adding immunotherapy further to it, again 15 to 20% addition, making it between 50 to 60% average. In small cell lung cancer, you are getting 80 to 90% response rates. So what is the benefit of adding immunotherapy? It is unlikely to add response rates. If it is adding, it will add only 5% maximum. So what's the benefit of adding immunotherapy in such situation? No, your voice is breaking.
Hello?
Yeah.
There has been minimal overall survival benefit wise. There has been found to have minimal overall survival benefits.
So how that overall survival benefit comes? If it is not increasing responses, how the survival benefit is coming? Yes. I think Pushpinder was messaged that durability of response it increases. So all the small cell cancers and even some other cancers are known to have very good responses to platinums, but the problem is that that response is not sustained for longer duration. And here the function of the immunotherapy is to somehow sustain the responses. And it was seen in both these trials that both the TIZO and DURVA trial, if you are adding it concurrent with chemotherapy and then maintaining it, it is going to show some benefit. Though there are negative trial of adjuvant pembro, there is negative trial of adjuvant nivo. So I think it is the trial designs were also responsible for the same. The trial had adjuvant pembro, the trial had adjuvant nivo, but that was after completion of the chemotherapy. And here, finally, the design which succeeded in both the trials was concurrent with chemotherapy and then later continuing as maintenance treatment. So this is something different from urinary bladder cancer, which is another disease where you see that patients have good response to chemotherapy, but responses are not sustained. So maintenance avelumab has shown survival benefit. Similarly, now there is data of Genesis Neo as well.
Okay.
Yeah.
So essentially, how is the management different from non-small cell lung cancer?
One is
So will you do molecular testing here? Any role for molecular testing?
Molecular testing, it's more using non-small cell lung cancer, especially adenocarcinoma.
You know of any molecular subtypes for small cell lung cancer?
Sir, it's like classic and variant forms. And then in that ASCL1, and then
Yes.
potential utility factor, and then neural ANP wave. I'm not sure
Yes,
about
so
that.
there are 4 subtypes, and I mean, in future maybe we may get more idea on which patients are more likely to respond to immunotherapy and also. So that is not in the, I mean, clinical stage. It's still under the research stage, but it may provide some idea, insights on which your patients are likely to respond to immunotherapy. So you should know about the molecular subtypes of small cell lung cancer also. Otherwise, there is no role for molecular testing.
Apart from that, we give PCA in small cell prophylactic cranial radiation, but otherwise we don't give in non-small cell lung cancer.
Okay. So this patient, will you plan for prophylactic anal radiation?
No, sir, we did not plan. Only we gave only 4 cycles of atezolizumab and then EP for 4 cycles, and then followed by reassessment. Patient was found to have a stable disease. Followed by that, we continued atezolizumab maintenance. But after 4 months of maintenance, the patient developed the relapse with brain mets. The patient had symptomatic like blood patient headache, and then the patient was found to have brain mets. Brain only meds, but otherwise other lesions are all stable. So we gave palliative whole brain RT for the lesion, and then we continued at now patient had systemic progression also after 4 months. Now patient was 10 lines.
So just a few words on management of relapsed small cell lung cancer. How will you manage when there is relapse?
When there is relapse, option would be second line would be topotecan or lurbinectedin.
So what about the platinum resistance in small cell lung cancer? What is the definition?
Yes, sir. Platinum sensitivity as per NCC, it's less than or equal to 6 months or more than 6 months.
No. I mean, small cell, it's not 6 months, no?
3 months. 3 months, more than
Yes.
3 months.
3 months. So if it's more than 3 months, you can re-challenge with the platinum. Otherwise, the option is topotecan. Okay. Okay.
Apart from topotecan, what are the other options? One of which is going to be available shortly in India?
Yes.
Lurbinectedin and tarlatamab.
Lurbinectedin and tarlatamab. Okay. Both are going to be available shortly, I think. That would be good.
What class of drug is lurbinectedin?
So lurbinectedin is an alkaloid, which has pleiotropic effect.
So what is the mechanism?
Sir, it induces apoptosis. It has inhibits transcription and causes DNA double-stranded breaks also. Pleiotropic effects.
Okay. So RNA polymerase inhibitor, right? Okay. Okay. Yeah. So that's it. Dr. Akil, you want to add something? And when you mention about chemotherapy regimens, clearly be ready to write the prescription. You should know everything. Like in the clinic, you will be just filling out the templates. But in exam, I think you should be knowing to completely write a chemo prescription. So all those things should you should be mentioning.
Yeah. Also, when you are not giving PCI, is there any data to avoid PCI by using any surveillance?
Yes, sir. We can do an MRI surveillance like every 3 months. Like every 3 months, it showed almost equal survival, like giving PCI followed by surveillance or with MRI surveillance alone. So based in Maverick.
Okay. So what is this study? From which country?
Maverick.
No?
Maverick.
Japanese study, basically, correct?
Yeah.
Yeah.
So
So,
read about those trials. Like I mean, now the significance is less in the immunotherapy era, but all these traditional trials on PCA, you read these two conflicting trials, both in extensive and limited, how they are different. So you should have some basic idea about these trials.
I think we have completed most of the relevant discussions, but yes, there needs to be a fine tuning, especially relevant to the paraneoplastic syndrome. This is a thing which you cannot answer if you have not read it well. Otherwise, it becomes difficult to answer. Apart from these points, the relevant trials of immunotherapy are important to understand and get idea. The differences in the trial should be relevant and should be very specific, and you should be able to enumerate them rapidly. At the same time, the second line treatment options, especially the data of the tarlatamab, lurbinectedin, are becoming important since we are be getting these drugs shortly as well. Apart from these, the drug sometimes we utilize taxanes as well, paclitaxel or docetaxel in the second line setting, in the second or third lines. These are important points which we see because most of the time patients' performance status deteriorate rapidly, but some patients have good performance status and you are going to utilize third line or fourth line treatment as well, but these are smaller fractions of the patients. You should be aware of the other available options. Also, re-challenge of the platinum is very important point, which was already highlighted by Dr. Manu. So I think these are the relevant and important points. And also some times we prefer utilizing prephase chemotherapy uh, instead of giving full dose chemotherapy in the first go. Most of the time, since it was being discussed that patients have poor performance status, we give something like prephase chemotherapy. Like there is an option to give either single agent carboplatin or reduce dose carbonate to on 2 days. So all these are customized options, though these are the options which can be utilized in the practice depending on the patient's performance status. I think we have discussed.
I think Dr. Akil has summarized everything, and Dr. Kale has presented well. So always streamline the discussions relevant to your particular patient, starting from the history, and don't miss out on the positive findings. And lung cancer, smoking related things, you have to read well, epidemiological things. Then other things related to small cell, Dr. Akil has already explained. Okay. And I think we can wind up.
Yeah.
Thank you, Dr. Kale. Dr. Akil, we can wind up now. I mean, Dr.
Munir.
Yes,
sure.
Okay.
We can. Thank you so much, Manu Prasad sir and Akil Kapoor sir, for your enlightenment.
All the best. Yeah.
Thank you.
Best of luck.
Thank you so much.
Yeah. Okay. Thank you, Akil. Thank you, Manu, for handling this the session, and it was a very good presentation. Many practical relevant issues were discussed. So thank you. We'll catch up. We'll be sharing up with the new presentation next month. Thank you. Thank you, Dr. Munir, for coordinating.
Good night. Good night, everyone. Okay.
Good night.
Good night.